Thank you. Thank you for that great introduction. Okay, we're going to start off with just a TV commercial that you might have seen. And then we'll jump in for today's talk.
I've seen beautiful things. I've seen the sunrise paint the desert, witnessed snowfall on the first day of spring. But the most beautiful thing I've ever seen was the image on a screen that helped our doctor see my wife's cancer was treatable.
GE Technologies help doctors detect cancer early so they can save more lives, bringing better health to more people.
You know, a number of us have probably seen that commercial play on television, along with others. And I want you to know that I'm so appreciative of you allowing me to come in and speak with you today, because it's people like us, people in this room, that actually make a difference in people's lives. And I talk about that with our engineers, with our QA people, with our marketing people, that everything that we do here is really about a patient. So as I kind of go around, first of all, let's not ever forget that we're all about patients. And that's really what drives a lot of us to get up in the morning. I am a lucky, lucky person. I can't wait to wake up in the morning. I've been able to kind of drive part of this industry that, 15, 20 years ago when I got into it, maybe wasn't quite as popular as it is now. And the joke, the inside joke was, so I've been published a few times, but my parents can't figure out what I do for a living. So they go, well, I don't understand, what do you do? So one time I actually got quoted in the New York Times. Actually, it was really exciting. I designed a study along with the CDC folks here, looking at H1N1 and secondary use of clinical data, streaming off an EMR within 24 hours to look for trending and outbreak of H1N1. And we got picked up by the Times, and I got quoted in it, and my mom saw that. So now all of a sudden she goes, well, I don't know what you do, but keep doing it. So, but that was the inside joke on I've been published. Look, we're going to talk about three things today. One, it's about data continuity, data access. How do we think about changing the game when we want to get to the future of healthcare? What are we really going to do that says, hey, what we do today is okay, but we need to be thinking differently about the future? We need to process that information into insight. It's not just having data in an enterprise data warehouse that's going to help us. And then the future is actually sooner than you think. Proteomic, genomic data, how do we make that translational medicine leap and get that into practice sooner? I'm going to speak a little bit about what we're doing at GE. As important, what we're doing from a nation, I also sit on a number of policy boards. I'm a board member to the advisory board for HL7, very active in the American Medical Informatics Association, and work on a number of policy position issues around that. So what we need to start thinking about is how do we actually reduce cost, drive access, and bring in quality of care, right? So that's our main thrust here. The second is, what are we going to do in deal with the new types of environment that we're dealing with? We're transitioning from kind of a fee-for-service to a pay-for-outcomes, quality type world. If you think that this CMS version of an accountable care organization is going to happen or not going to happen, I just kind of look at the trends in the industry. I see where some of the largest payers are going. Great organizations like United Healthcare that now owns a technology called Axolotl, and Aetna that owns a company called Medicity are data exchange technologies. So they're looking to figure out how to bring that data together, which is one of our biggest challenges. How do we stop the silos that we kind of have in healthcare and bring that all together? We need to start thinking really importantly about where the future of healthcare delivery is going to be. How is this new world going to actually drive new information about our patients? I'll submit to you that probably easily within 10 years, the vast majority of information about our patients will not come from the interaction of a patient in front of a physician or a clinician, but probably from some outside source, whether it's remote monitoring of their chronic disease at home, whether it's coupling that information with where we're going and how we're going to bring information about their lifestyles together, whether it's social networking environments. We had a great study that we did with AstraZeneca looking at social networking. So we own we still own 49% of NBC Universal. A couple of years ago, we went and we're looking at a opportunity to drive compliance. and figure out a way to really help these patients really adhere to a regime for their care. And I'm not going to get into who we did the study with and all that, but what was interesting was in medicine, and how many people out there are nursing physicians, just by raise of hands? Okay, do we have any administrative staff out there? CIO, CMO, or CEO types? Okay, rest are more business type? Okay, and we're all patients, by the way, so let's not forget that we're still all patients. So what we did was, here's the traditional methodology. I'll take myself as an example with my own cardiologist. Hey, Mark, you're doing good, your signs are all right, your cholesterol's good, you got to lose weight, you got to exercise, blah, 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 blah. And we said, well, that doesn't really work that well, right? Compliance isn't that great. Most patients, after about 90 days, about a third aren't taking their medicine at all. Another third aren't taking it correctly. So what we're kind of doing isn't working. So we said, let's go to this TV show, this Biggest Loser TV show we own. And these guys are generating blogs, they're having groups, people are getting communities at their work office place and creating environments, and they're going like, hey, follow us, we're having fun, and by the way, we're going to affect your health care in a positive way. I said, geez, let's get some of those guys in the room and tell everybody with little initials behind their name to be quiet for about the first 4 hours and listen. God gave us 2 ears and 1 mouth. We should listen twice as much as we speak. And it was wonderful. We learned so much about social networking, social environments, how to use social media, what it really takes to be a community. Actually, this concept that they had this sense of privacy and yet they were part of a community because they were doing this over the internet was really interesting concept. And the study showed such dramatic results, and it was around gastric reflux disease, and we call it the gastric spotlight. So it clearly wasn't because we came up with a snazzy name, but the way we implemented advanced decision support coupled with social networking drove compliance through the roof. So much so that we all redid the study because we couldn't believe that we got the response we got. So this whole concept of where are we going to go, what are we thinking about remote monitoring, where's that future happening, and then finally, 3 revolutions in medicine. We're in the 3rd revolution right now. First revolution is doctor, wash your hands. People will come off and survive a battlefield wound in the Civil War, survive the amputation, and die of sepsis. Doctors would wash their hands after the procedure. You were dirty, you're bloody, you were from in the field. Second revolution, 30s, in that era. Hey, there's this thing called a microbe, and this is bacteria, and it's killing you. And we're going to come up with this other thing called penicillin, and it's going to kill the little thing you can't see either, and it's going to really decrease infection rate. Infectious model of disease, the biology model of disease, 2nd revolution. 3rd revolution is now. We're all living it. You will look back, and we will have the pleasure and honor of saying we really were at the groundswell of this 3rd revolution, and that is the use of genomic and proteomic data and how that can really affect change for our patients. Not only will we now broadcast a therapeutic for an oncology patient, but we'll now target a therapeutic based upon their genomic makeup. So we'll know which genes, which therapeutics will be most effective given that gene therapy or that genetic makeup. Informatics is critical to all this. We are the conduit. We will be the way that will put the rule, the guideline in action. So it is what we all do for a living, health IT, what's happening in Georgia, that will lead the nation in the adoption of this 3rd revolution in medicine. Why do we need IT? Knowledge in medicine is doubling every 8 years. Half as much as you needed to know every 8 years. More difficult than that, I need to unlearn what I thought was right. So it's impossible to really kind of keep current. There was actually a study done that said, gee, all you have to do is read about 27 articles a day, 365 days a year, and you might be able to stay current. Here's where information technology can really help drive that knowledge management, that evidence-based medicine. But we need to get data to do that. We need to bring that data together. And if we don't think medicine's complex, and is just a little bit more complex than putting it into an ATM machine, this is the environment that we work in. So there is a patient in there. What we need to do is make sure that we don't forget about that patient, and that we, forgive my fonts that got messed up, so I want to give credit to this physician that shot this photo. But this is what we're in why we all get up in the morning. How do we make this environment a safe environment for a patient, really get down to the team concept of delivering care for our patient, no longer the individual, but it's now a team approach to our patients, and then how do we make sure that we monitor that effect so we're driving the best outcome possible for our patients? Well, to do that, you have to start thinking about care coordination, engagement of our patients. Patient engagement is critical in all of this. Quality improvement, privacy, and if you saw down there, it would be population health management. So the real issue is that we're now in a world of population health management. We're actually cutting off some of the slide, so if you can, maybe change the resolution, that might get us back on track a little bit. So let's talk about data integration. This is where we kind of are today. Point to point on the top part of the slide, interfacing, pain in the neck. We all know how burdensome it is, how expensive it is. And what it does is it creates silos, right? You can have great institutions across the street from each other, and they can't share information about the same patient that goes to both institutions. Health information exchanges are here. They're early, but compared to where we are, they're wonderful. What we need to do is start to make sure that we push enough standards, and really it's not the standards issue. In fact, the challenge in medicine isn't that there's a lack of standards. We have too many standards, right? You have HL7, you have LOINC, you have ICD-9, you have CPT, you have LMNOP, you're a homegrown, everyone has a standard for something. Genomic standards are how we're going to look at data, family history standards for patient. Smoking tracking, there are 40 different ways we track smoking history in our electronic medical record. And a computer only really knows a 0 or a 1. So our world is to harmonize those standards, to bring those together and to drive the adoption of them so we can now make sure that a Verizon cell phone can talk to an AT&T cell phone, though I'll give Verizon a plug. My AT&T service will probably drop the call. But you want to be able to make sure that there's a continuity across the healthcare continuum. And that's where health information exchange is there. Now, the reality is we need to go far beyond a health information exchange because there's some folks that aren't electronic and we need to keep them in the community. So you have to be able to have your patient at the center. You want to look at the hospital. You want to look at the community health center. You want to look at other group practices. You want to be a network of networks, other HIEs, bringing that together. Let's not ever forget about the family. I'm kind of going through this right now, bluntly. My wife, and it's really the women in this audience, will spend more time taking care of her parents and her significant other's parents than their own children. Okay? That's where we are in our nation right now. So my wife is actually helping to manage the health care of my 81-year-old dad and 80-year-old mom and handicapped older sister that still lives with mom and dad. And boy, it's a challenge. We're in the process of kind of relocating them. They're in Texas, I'm up in Boston, and how do we coordinate all the different appointments, all the different medicines, where they have to be at the right place at the right time, who's managing their care, and who's driving that continuity of care. So let me tell you something, if we don't think we all need to get up in the morning and do a great job just because it's the right thing to do, we want to do a great job for our own families. And this is one area that I know that when we start to think about, bringing in the ability to view information over the internet for those doctors that aren't electronic, because there's still a lot that are in that sweeping mode up there. We want to make sure that we have patient online, that our patients can have the information. So we actually kind of kludged up, the geek that I am, away from my dad to kind of simply get his information in so I can kind of review all of his clinical data and then view that because his practice that he goes to is not electronic yet and get a lot of that information. So this is critical about engaging the patient and how we're going to do this. And then finally, let's not forget the whole issue around imaging and imaging technology. We have running in Sweden right now a chunk of the country where every study, whether it's a GE system, a Siemens systems, a Philips systems, an AGFA system, right, whatever the legacy PACS archiving system is centrally downloads to a repository that GE manages, because remember I told you about, there's the issue in healthcare is not that we don't have a standard, that we have too many standards. So the imaging standard is DICOM, right, for those that you want to kind of think about that, but it's what flavor of DICOM are you running. So here's what typically happens. You're a patient. You're a good patient. You got your CD from your previous doctor. You go to doctor 2 and it says, hey doctor, I got all my stuff right here. And he puts it in there, or she puts it in the machine. It's supposed to be a DICOM readable image, and it doesn't open. And in the next 35 to 45 minutes, somebody in the office is downloading drivers and trying to make this thing work and going crazy. And then finally what happens is, okay, just reorder the film. Okay? That's reality. This technology is a simple technology where it brings together and manages all those different standards. Now, what's interesting in the world of data transmission, let's look at our wounded heroes coming back from theater. How do we make sure that those wounded heroes are getting that information and brought across? So there's a congressional mandate for the Department of Defense and the VA to bring together the two charts. And they have a mandate out there. We can either choose to go off and try to build this stuff, or look for solutions that you all represent, that we represent, that are available today, that other parts of the world are doing today, and can affect a change quickly. So we need to make sure that we allow for research to happen, and funding of research is super critical, but let's not also forget that there are a lot of great technologies that are in this room that can really affect change quickly, and that's what we need as a society. So second thing is, what happens once you start to get all this data brought together? A friend, Brent James, Intermountain Healthcare, and he truly, if I think of myself as the computer geek physician, he really is, right? He's one of the geekier guys out there. So Brent is one of the lead researchers at Intermountain, a very strong proponent of lean and Six Sigma concepts in healthcare. How do we find the problem before it actually occurs and take that out through workflows? And it's realistically a holistic approach to data. So you bring all this information in, you create data repositories. You have to start to now normalize that data, because remember, I told you there are 40 different ways to talk about smoking, but the computer only kind of knows 0 and a 1, and we have to make sure that that's continuous across that. And that's actually some of the work that we're doing around data quality and terminology services. How do you represent myocardial infarction? How do you represent blood pressure? Sounds simple. Blood pressure should be easy. It's just two numbers, a systolic and a diastolic. Well, wait a minute. Left arm, right arm, sitting, lying, standing, exercise, with contrast, with medicines. There are 14, 30 different ways of representing blood pressure. So there's a lot of work to be done out there when we say, gee, how come the standards aren't there to get those great rules that Intermountain Healthcare, a Mayo, a Geisinger, a Kaiser Permanente, they have these wonderful systems, and they are wonderful. They have great enterprise data warehouses. They aggregate the data, and the little secret is that they have teams of informatics people behind the scenes making those systems hum. The challenge for all of us is to say, how can we start to automate some of what is manual there, leverage their best practices, and then get that out to the community hospital? And that's what GE is spending a lot of energy doing. So here's a great example. Acute respiratory distress syndrome, bad, 90% fatality rate, okay? By using a protocol, and all you have to do is remember at 3 o'clock in the morning, page 5, 2 paragraphs in, of what this paper protocol is, right? Because everyone can do that. Putting this in an automated format, they're able to get the survival rate up to about 45, 47%. As important, they also drove down the cost of care. Oh, actually, I'm sorry, this is the cardiology one. This is one around ACE inhibitor. Everyone knows that we should be on an ACE inhibitor. This is not controversial. Intermountain does better than most. The average facility in the States is about 55% of the time they get you on an ACE inhibitor. Intermountain started out about 65%. They got it up to 95%, which is about where you should be with normal human variation. Able to decrease readmissions by 500 plus 550. Think about that when we're in a accountable care world and the importance of that. Cost savings around 2.4, 2.5 million. Most important, saved about 300 plus odd lives. This is the one, ventilator weaning. We're able to really decrease the mortality rate significantly. We're able to get people off a ventilator 8 hours sooner by using this protocol. And again, was really started to think about what we can do to drive that quality, that best practice outcome. Well, here's what we're doing to say, that's wonderful if you're Kaiser Permanente. That's wonderful if you're Mayo Clinic or Harvard Partners or XYZ, okay? How do we now take that, use that knowledge, and get that down to even a moderate-sized facility, a 400 or 500-bed, 300-bed facility, and then down to that 200-bed facility or smaller? So we actually built a technology that layers in on top of, well, hopefully you have a GE system, but we know that that's not the case. You might be running an Epic or a Siemens or a McKesson or whatever, Meditech. It'll sit on top of that technology and say, hey, you know what, let's look at and have a rules-driven way to view data, so you can actually view this data in real time. It'll pull data out of your legacy system. So basically everyone says, oh, well, I have a fully integrated system. Hey, that talks about lab, pharmacy, nursing documentation, CPOE, a couple other things, and I've never been in a hospital yet that doesn't have at least 30 to 40 other things running. We want data from all 30 or 40 other things put into an enterprise data warehouse. That's how you go from, I can do a simple alert, to I can affect change on something that is serious as acute respiratory distress, is by getting that really robust enterprise data warehouse. What we chose to look at with Mayo Clinic was infection rate in the ICU and how we could affect a change. So we started looking at, well, what's the dwell time for Foley catheters? And this, this is information that's out there. And how do you bring that in? How do I have workflows? So in real time, don't tell me tomorrow that, gee, you should have, those 4 diabetics you had in yesterday, 2 of which needed to get the foot exam done to meet your criteria. No, I want to know that in real time. Right? That's what we're here to do. That's what we can do. Bring that all together, start to look at rules and guidelines, and put that layered in on top in real time. But then also recognize that there's a whole world of technology that's out there, and you have to go and affect the order for this new Foley catheter. Go back to the legacy system and order it there. So again, how do you migrate people forward to get onto a modern architecture that'll take us forward? And here's a little bit of geeky talk. So we're a big proponent of something called SOA, services-oriented architecture, right? It really allows one to have a very open world where we want to foster innovation. So instead of, you can now have almost the app store concept, which is what we're building here. It'll be a GE CPOE module, and as we speak, Intermountain Healthcare is building its own CPOE module, computerized physician order entry module, and we're going to be competing head-to-head, right? Because you can write to the same app layer, right? That's the fundamental difference. That's when you start to get truly open standards, because this is open architecture under the hood. So let's let those young team of individuals really be innovative and bring that and foster that innovation and bluntly drive some job growth and creation, right? Because that's what's really going to take to get our nation going. This is one around stroke, door to CT time. You see that, unfortunately, in Gloria, we made it to CT, but we did not make it within the protocol timeline. We got a red check there. On John, we know we have 25 minutes left. By the way, this will escalate, so if John's busy, or the nursing care that's taking care of John, it needs to get him to CT, it'll start to alert to managers up the food chain. Our goal here is, again, in real time, affect the change we need to drive the best possible outcome for our patients. So what are we thinking about for the future, right? Where do we need to go with this? Well, if we want to start managing the patient, it's about interoperability. We've already talked about the need to be collaborative in our approach, right? It's about the hospital working with the primary care physicians and all the specialists and bringing all that forward. It's really about analytics. We haven't talked too much about this, but that enterprise data warehouse, there's huge opportunity for secondary use of this data to really do the analytics around this data. We do some wonderful work with our streaming data off of one of our other electronic medical records and how we do research with that. And I'm going to talk about that in a second. Accountability. Boy, in this day and age, if we can't show how we're not only going to manage the patient better, but we're going to bend that cost curve of the cost to our nation, that has to be part of our conversation in this day and age. And then finally, we've gone from a world of and we'll stay in this world. We have to take care of our patients, but now we're managing populations of patients, especially as we start to bundle payment, and that gets more pervasive across the nation. So where are we from a population health management perspective? We're really very excited to be working again with the CDC Alliance of Chicago, so I'll give them a plug up their community health center in Chicago, and the Chicago Department of Public Health looking at foodborne illness and active alerting using interoperability standards. So it's not a GE stuff. We're doing this research, and it'll be able to be consumed by any certified electronic medical record out there. What it does and what it can do is say, hey, doctor, if patient comes in with low back pain, continue to do your job, not affected. But mom brings in little Sally, and Sally's complaining of a tummy ache and some diarrhea. You're thinking, the kid's got got a bug, right? No big deal, send them out. Starts to put in chief complaints, symptoms into the system in real time. It's pinging a CDC server behind the scenes so the doctor doesn't get alert fatigue. There's passive to the physician, the clinicians. But if the alert comes back and says, hey, wait a minute, Chicago Department of Public Health says this patient lives within this geographic area and the local Denny's is spewing out salmonella, right? This clinician needs to know this in real time. And it goes, hey, doc, you might not know this, but there's an alert in your area, click. And it says, it tells you, here's the restaurant we think is in question. Ask your patient if they were there. Would you please get a stool culture and send the results to the Chicago Department of Public Health? And here's the recommended treatment. Why did we pick foodborne illness? We could have chose anything in the world. It was our choice. Chose foodborne illness because this is a breakthrough in healthcare IT. This is where we need to be thinking as an industry. What's the breakthrough? If I go to put in an alert around, let's take diabetes. I have to do the foot exam. Or gee, did I get mom and talk to mom about use of car seat? That rule hasn't changed in a real long time and is not going to change. Almost any vendor worth their salt better be able to get that type of rule into their electronic medical record. But you take an alert like a public health alert around foodborne illness in a very small geographic area that might only be valid for 10 days. That never gets put into electronic health record, right? But this is a demonstration project of how we can move as a nation. This is a quantum leap forward in how we manage content. One of the biggest challenges for any of our institutions, healthcare institutions, is managing the content and bringing that forward. This is transformational. So we're actually, we have it all kind of built. Our first go-live patient should be within about 4 to 5 weeks. It's going to run for 6 months. Hopefully at HIMSS, we'll be able to make some announcement at HIMSS, and then we're going to run it for the rest of the year, and then we'll look to be published in a peer-reviewed journal. So very exciting work that's kind of out there. Geisinger, we're very fortunate that both Intermountain, Mayo, Geisinger are GE customers. Some of them use some of our technology, some of them very little. Intermountain actually uses almost no GE technology other than a couple of departmentals, and we have this wonderful co-development that we sit on top of their homegrown health system. Remember that concept that we have to live in the environment that's already existing but add value? What we're doing with Geisinger is saying, hey, how do you start to think about population health management now? So they're taking it to the next leap. They've already done that analytics on the database for the patient. Now they're looking to drive population health management work, and we're part of their team that's looking at that. How are we going to decrease admissions and decrease readmissions by 36? These are the target numbers that they're working with. We talked a little bit about this data, secondary use of data for research. That was part of my intro. I am a data hound. Right? How can we go to the FDA and start thinking differently about how we do clinical research? If we have these EMRs that we've all invested in as a nation, how do we make sure that data now can be leveraged and add value? And again, here's where you can do the right thing and how do you do well and do good at the same time, right? So let's look at use of data for clinical research. We have 22 million lives in an anonymized data set, HIPAA compliant. We already have talked about H1N1 that we use this data for. We're using the same data set for this research project I just described, looking at foodborne illness. And what we're also going to be looking at is how do we think differently about doing drug development? Why can't I start to model trials based upon predictive modeling from this data? We're actually doing it. Really proud of this. So top 10 pharma in the world are actually working with us in this data set to model their protocols. Why is that important? If we can save time off the drug development cycle time, it can have a great effect on our patients. It gets new therapeutics into market sooner. right? At the end of the day, that's what we're trying to do. Now, let's put the GE suit hat on, because I can save the world, but I have to have a business case to do it, is kind of like what GE tells me. Same scenario. Let's say by use of this data, we can recruit patients and save 4 months, just 4 months, off of recruiting patients into a large clinical trial. What's interesting is that if you do that, right, average large trial is $1 million a day to run. You save 4 months off $1 million a day. A lot of money. I'm going to suggest to you that that's actually chump change. Let's go talk to Pfizer that has Lipitor at $8 billion a year. If I gave them 4 months, in essence what I gave them was 4 additional months of patent-protected sale. I saved them 4 months, and in essence they have 4 additional months of patent-protected sale. That's $2 billion to their bottom line before that goes off and goes on to generic, okay? So again, we can do the right thing and do well by business at the same time. What I'm hopeful and what I'm really excited about is that therapeutics that might have been orphaned because they just weren't, they cost so much to get a new therapeutic into market, we now can drive down the cost of that, bring jobs back to America, because right now 50% of all clinical trials are not done in America anymore, right? They're done outside. And that number is actually going up. We need to stem that. We need to make sure that people want to do research in our country. We want to make sure that we bring that back. This is ways that we can be innovative that most parts of the world can't do on the scale that the US can do it on. And then there's the whole issue around chronic disease management. Definitely want to talk about disparity of care. So here's where we talked about, I bet you 10 years from now, the vast majority of information on our patient will not be coming from the actual physician-doctor interaction, but external monitoring that comes in, and this is what we're doing. We have an alliance with Intel. You might see their banners back there. We're really proud of that, what they're doing. Looking at information, how to bring that back together. We have wearable devices we're doing research on, so when a patient comes into the ED, and this is how this all started. Instead of having all those GE wires, to the GE monitoring equipment, how do we make it simpler to get the patient from the ED to the OR to the ICU? And we started looking at, wireless monitoring technology, wearable devices that are disposable, okay? Then we said, well, if we can do that inside the hospital, we can do that at home. How do I make sure my congestive heart failure patient doesn't end up in my emergency department at 2 o'clock in the morning, because I'm going to catch their small weight gain much earlier and send that to a knowledge worker who can intervene. Case management. This is research we looked at in the home, looking at just sleep. Passive, no cameras, no anything, just looking at, actually with sensor technology, actually security sensors that were repurposed. Top one is a normal sleep pattern. Second one is somebody that has sleep apnea. The bottom one that got cut off is actually somebody with dementia, right? So it actually is somebody that has mild cognitive impairment. So we're really doing a lot of research around Alzheimer's disease. We think that, when we need to start to, think about our nation, this is a disease that unfortunately a lot of us will ultimately end up with. There's a lot of personal connection to this area. So there's a lot of us that want to do research around this. What's interesting about this is, when it was extremely inexpensive to do, in the same technology, we're actually looking to see how we could put in maybe corridors in a patient's home to look for gait and gait analysis. One of the main reasons somebody gets institutionalized, gets taken out of their home and put into a nursing home, is fall risk and risk of fall. And what if we can be predictive in doing that? So we're doing that research. It's a shared infrastructure. It's using e-health solutions, so they're bringing that data together. It's looking at home health and how we bring all that together. And then there's the fun part about genomics. This is really exciting work. Yeah, you read the slide. Very good. What's exciting about that, right? What's exciting about that is we can start to think about, gee, if you have the right or unfortunately have the right genomic makeup, do we need to intervene sooner with colonoscopy than waiting till you're 50? Or if we're looking at pharmacogenomics, is this the right therapeutic for you to have at this point in time based upon your genetic makeup? The ERISA, the drug ERISA is the one that's always cited. I'll even go warfarin. Warfarin, there was a label change by the FDA about warfarin, the blood thinning drug, okay, about 24 months ago. They said they suggest getting a genomic study. Why is that important? Warfarin, it takes a long time to titrate appropriately, because if you give too much, you can bleed to death. Well, the reason you give too much is there's a subset of the population that has something called the cytochrome P450 gene that makes you a fast acetylator of this drug. So or a slow acetylator of this drug, okay? So you have to do this slowly. Well, your highest risk of your second heart attack is actually during the same period you're trying to titrate warfarin. So the 30 days after your first MI is the highest risk you're going to have your second MI, your heart attack. And there's actually a study out there, a test out there that you can run that says, yeah, your liver is either a fast acetylator or a slow acetylator, and it helps the clinician titrate you faster, right? Today, this is where I'm talking about the future is sooner than you think. Genomics is really exciting, and it's not linear, okay? So if we start to let's look at myocardial infarction, right? The genes for myocardial infarction are actually close to the Alzheimer gene. Isn't that cool? If you start to think about it, you say, well, geez, myocardial infarction, a lot of that is because of plaque. Alzheimer's had these amyloid bodies in the brain, which are basically plaque. Well, that kind of makes sense, right? But we have to start to unlock this. Let's look at cardiomyopathy is actually close to muscular dystrophy. So because the way the genome is tangled back in and of itself, right, what can we start to do to think differently about how we're going to do this? I'm going to end on this slide. We're doing research right now around Alzheimer's prognosis, basically looking at large data sets and do predictive modeling of disease. We make jet engines. Those jet engines, good thing, are monitored every time they're turned on, but they spew out huge amounts of data, so much so that humans can't really monitor it. What has to happen is that you have to be able to have algorithms built that will look at very large data sets, find signal within that, and then be predictive of that signal. So we actually got to the point right now that our engines are running at like 15 sigma of defect, which is good for all of us, because especially me, I do about 150,000 to 200,000 miles a year. What's really exciting is that they were able to go, yeah, hey, you know what? This one slice of data looks normal, this slice of data looks normal, this slice of data looks normal, but when they're taken in aggregate, it's predictive of a failure at 300 hours. When that plane lands for its next 100 hour, instead of waiting for 300, change out this widget in the compressor and you take out the defect before it even occurs. We're really good at that. I said, wow, that's healthcare. We got all this data. Yeah, Intermountain, Mayo, Geisinger, Kaiser, they got dozens and dozens of people that can do analytics on that data. We said, we have to automate this. Because now when I start getting that home health data, where's the Intel people? I don't want to look at it as the doctor, right? I don't want to see that. I need somebody to actually do the analytics on that and get me the result. So that's some of the research we're doing right now. I want to leave time for a couple of questions. I want to thank you all for your time. I know how hard it is to get out of, to clear time on a busy day. I think this is an outstanding organization, and I'm really happy to be able to support it. Thank you.